Hello, good evening. Good evening, everyone. Can we hear me?
Yes, sir.
All right, good evening. Thank you for joining. We're all welcome to class. Okay, I can see more people are joining. We are welcome to class today. Once again, our sincere apologies that we couldn't hold class on Sunday. Thank you so much for being available for class today. So we'll be starting the session right about now. You're welcome to week 5 of the JIIPCC Mentorship and Internship program for the Medical Health Tech and Law class. In today's class, we'll be discussing healthcare contracts and transactions, right? So we'll be taking presentations first, as is in our practice, take presentations first, and then Mr. Ebenezer will come up to give feedback to the presentation and to also have the discourse for the session. So please, if we have our presenters in class for group 1 and group 2, we'll be taking your presentation right about now. So yeah, would like to first go ahead. Are the group presenters in class? And please, okay, before we start, can we kindly reach out to members of our group so that we can have more people joining for class? We are quite scanty in the session. All right, I will send reminders to get people on board, but can we kindly do well to send reminders into our subgroup?
Hello, Dennis.
Hello, sir.
Yes, how many people are in this class now? Only 6. I can see 6 people. Okay,
Yes,
out
sir.
of the 6, those in group 1, indicate on the chat box. Those in group 2, indicate on the chat box. Let me know how many. But the class we go on is just that I don't know the measures you are taking to penalize those who are not in class. The class will go on, but okay, group 1, Venice, group 1, okay, those in group 2, so that I don't want it to be lopsided, maybe only one person in group 1, then the other 5 are in group 2. So, participants, also reach out to your group members, tell them the class has started.
Hello, sir.
Yes, proceed. Let the group 1, okay, group 2, let the group 1 start their presentation so that we finish on time.
All right, thank you very much, sir. So yes, we'll be taking presentation from first, right? So if the presenter is in class, please let's quickly do that.
Okay, good evening, sir. I'm the presenter
Yes,
for
good
group 1.
Yes, you can go ahead. Thank you.
Okay, sir, please can you share the slides? I'm finding it difficult to do so.
All right, just give me a minute. Let me get your slides.
Okay, sir.
Okay, so it will soon be coming up. I just want to.
Okay, sir.
All right, can you see my screen?
Yes, I can. Thank you very much, sir.
All right,
Good evening.
go ahead.
Okay, good evening, everyone. My name is Benny Suzanne, and I'm the presenter for group 1. Our topic is healthcare contracts and transactions. Please, I hope I'm audible.
Yes, you are.
Okay, so healthcare contracts and transactions. Next slide, please. So the presentation is going to take place from 12 different subtopics. The first one is healthcare provider contracts, negotiation strategies, hospital physician contracts, managed care contracts, and insurance contracts. The first five I'm going to be talking about the contracts and the people that are involved in making of these contracts. So I'll start with healthcare provider contracts. So as you all know, contracts and agreements between two or more parties. And healthcare provider contracts, they are legally binding agreements between the healthcare provider, which in this case is either be the hospital, the physicians, the clinics, and other parties such as
After my class, I did class.
companies. These companies are called HMO. That is the Health Maintenance
Do
Organization.
another class. After my
Next,
class, I'll go drop message for WhatsApp.
If you are not the one presenting, kindly mute your mic. If you are not the presenter, please mute your mic. Benny.
Okay. Next. Okay, sir. Next slide, please. Okay, so I already explained what healthcare provider contract is and the people that are involved in the making of that contract, which is the providers and the insurers. So now the importance of this kind of contract is for financial sustainability. For example, the providers now that are going to be assured of the finance that they'll be getting, that are going to be paid for the service they're offering to the patient. Also, they're also going to be made to provide quality care. I will give more explanations on this later when I explain value-based contracts. And also, they're going to be made to follow regulatory compliance, such as data privacy and data protection laws, because but in the drafting of these contracts, the compliance, that's the regulations, are usually made necessary for both parties to follow. Next slide, please. So the objectives of healthcare contracts, what I'm just giving right now is an introduction. That's the objectives, the scope, and why it's very important. So the objective of this kind of contract is that it allows for reimbursement, service scope, quality standards, and performance metrics. So when these contracts are in place, it's going to show a clearly defined way of reimbursing the providers for the service they're offering. Is going to define the scope. That is the type of service the providers are going to offer. For example, is it going to be X-ray? Is it going to be lab tests? Is it going to be surgeries? Then quality standards is going to ensure that the work that the providers are offering are up to par, are up to standard with what they are supposed to, to perform. Then the performance metrics. For example, in value-based contracts now, where they are being paid according to the outcome or the quality of their work. So if they're not performing based on how they're supposed to perform, it's going to, reflect in the finance. They're not going to be maybe paid as much as they're supposed to be paid because of the low quality or low performance. Next slide, please. So this is just like what I've said, the scope is like what it involves. So the first one is the parties that are involved. I explained this earlier. That's the healthcare provider, the individual physician, the parties involved. That's the first part of the scope. That's the individual physician, the hospital, the clinic. These ones are usually called the providers. Then the other ones are the insurers. The insurers, they could either be private insurers or public insurers. Then the service area. So now in the making of the contract, they have to ensure that the doctors, the physicians, they are licensed to practice in a particular geographical area. For example, a doctor that is licensed to practice in Nigeria may not be licensed to practice in South Africa. So all of this needs to be included in the contract. Next slide, please. So this particular slide is talking about the scope of the contract. So you need contract term and terminations. What are the terms that will be involved that would lead to a termination of the contract? What form of malpractice will the provider or insurer engage in that will lead to a termination of the contract? Then the duration of the contract, will it last for 1 month, 1 year, or 3 years? All of those things will be specified in the contract. Then renewal terms. So definitely I'm going to put in the terms for renewal, maybe after every day or after every 2 years, because times are changing, and with it, you must provide the measures in which the contracts must also be changed. Then liability and indemnification. So the first one we have there is provider liability. That is for the physicians now. Is to define the provider responsibility for any claims arising for their services, and indemnification. That is who will bear responsibility for the loss. So will it be the payer, that's the insurance company, or will it be the provider? Those are the doctors now. So the contract is going to specify who is going to bear the responsibility, or let me just call it the liability for the loss. Then the specific types of contracts, as I mentioned earlier in the beginning, there are different types. We have fee for service, we have capitation, we have bundled payments, we have value-based contracts. So the contract now is going to specify what kind of contract are we entering into. Is it going to be fee for service? Is it going to be capitation? So the contract to specify what kind of payment method we are going to use. If it's not clearly laid down, then that is not a good contract. Next slide, please. So the challenges that arise out of this contract is that, one, complexity. The nature of this hospital, physician, or healthcare contract is that it's usually very complex, it's very tedious. So you need an expert or a person with high understanding of the nature of what goes on in the hospital or what goes on in insurance company that would be able to draft this contract. If not, there'll be a lot of confusing things, and you need to guarantee or cover all the wide range of scope. So a person who is an expert in this area would be best suitable to draft this contract. The number two, changing reimbursement models. So as I said earlier, we easily adapt to change. So things are changing very fast. What was obtainable last year is not what's obtainable this year. What 25,000 naira can afford last year you cannot use it to buy the same to get the same things you can get this year. So now, because of the reimbursement models that are changing, you must be ready to adjust your contract, to adjust the terms you have agreed on to suit these reimbursement models. And thirdly, data privacy and security. So the contracts must comply with data privacy and regulations, because it is becoming increasingly alarming to protect patients' records or the patient's records or their personal information, and avoid it to prevent it from getting out. Then negotiation. So before you reach an agreement, or before you agree to the terms of a contract, both parties will have to negotiate, will have to discuss, and come to an agreement, the things that they are planning. So it's very important to have negotiation. That's where both parties will bring out their interests and pick which side will fit them more. But I'll be explaining negotiation in the next subtopic, so I'll explain this more. Next slide, please. So negotiation. So in every healthcare interaction that's in a contract now, you need to negotiate. That's between the providers and the insurance company. They need to negotiate. Now, while it may not necessarily be limited to financial decisions, it has to cover patient rights, the payment model, the type of contracts they want to enter into, the treatment plans and care plans. All of these would have to be discussed, so that they understand the kind of method or the kind of plan they're going to undergo. Next slide. So the first key element in negotiation is preparation. So the first one is to understand stakeholders, where you understand your different goals and motive for the contract you'll be making. The second is adequate research, where you get to understand the cost of treatment, the treatment options and outcomes or regulations. For example, if the insurance company is going to cover, let me say, delivery, first they're going to have to find out normally how much do you charge for delivery. If you say, okay, 20,000 naira, you understand that when they're fixing a particular that contract, it's going to be maybe from 18 to 20,000 naira. They're going to fix the reimbursement plan. That's just an example of adequate research. You have to go back and check before coming to agree on a fixed amount for a contract. Then clarification of objectives. For example, they're going to have to pick which to understand why they're doing a particular thing. So for clarification of objectives now, for private insurers, you understand that they're doing it for their own profits or for their own gain, while the government might be doing it to sustain their own people. So if you're entering into a contract with the private insurer, you understand that, okay, this this party, they are here for their gain. So it's better to understand what to clarify the objective for each party. The fourth one rather, assessing the negotiation style. So in this particular place, they mentioned the Thomas Kilman instrument. So the Thomas Kilman instrument is just simply means conflict management. It was formed by Thomas Kenneth and Kilman in the year 1970. So there are two major methods of this Thomas Kilman instrument, which is assertiveness and cooperativeness. So assertiveness, this means where one party would want to put his own interest above the other. Then cooperativeness, it means when the other party or when like one party now is putting the other party's interest above his own. Like you're considering another person before yourself. And there are 5 methods to this Thomas Kilman instrument. The first one is the competing method, where you pursue your own goals. The second one is collaborating method. This is a win-win situation where you like each side will have to do something that both sides will get benefits out of it. Then the compromising method, this side is so that each party will have to give up something, you have to sacrifice a particular thing to be able to reach an agreement. Then we have the avoiding method. This is where you just avoid conflict instead of addressing it. And this avoiding method is usually done when the emotional intensity is very high. For example, imagine a patient is involved in this kind of negotiation and the patient maybe is very sick and it's like, okay, how will I survive this? Where will I get the money from? And these people are busy battling the cost of all of this. So it's really very difficult to do that before the patient, and most times they have to be involved in this negotiation process. So for the avoiding method, most times it's best to just follow this method to delay conflict or delay everything instead of addressing it immediately. Then the last one is accommodating method. This one is just maybe the party now just giving to whatever the other party is saying in order to maintain peace. And this is very important when you are looking towards a lifelong partnership or a long-term partnership. If you know that, okay, this company or this party will be useful to me later in the future, you may just want to accommodate the person's interest and just give in to whatever the other party would want, just to secure and maintain your relationship. And the last one is the plan alternatives. So it is also very important to explore all available options that are available to you, so that you can make the best decision out of a negotiated agreement. Next slide, please. So tactics. This is the second key element while negotiating. So I've explained most of it here. So the second one I'll just explain here is that's the second point under tactics, is use the YEAR framework. That's hear, empathize, analyze, and respond. That's the YEAR framework. Then the multi-party simulations, practical sessions where stakeholders must reach a consensus and can be a go-to tactic. So for tactics, the most important thing here is just that usually the person who has more bargaining power is the person who does not have so much to lose, or usually is the insurance company that has more bargaining power, because they are the ones that are going to be paying for the service. So usually they have more bargaining power. But providers must ensure that they represent their best interest in whatever they're going to be negotiating. Next slide, please. So overcoming challenges. So now, because of the problems that may arise out of negotiating, the first one is conflicting interest. So everybody wants what benefits them. The parties would want access, insurer would want cost control, providers want resources. So using integrative bargaining, just as I said earlier, the win-win solution. And the win-win is like collaborating. Everybody will just work so that they can all get something or get a benefit out of it. The emotional intensity. Of course, I said this earlier too. This is like a life or death situation, especially for the patients. So this can heighten emotions. So active listening can reduce tension. Then number 3, resource scarcity. So in situations of limited intensive care unit or dialysis machine, ethical framework or transparent criteria help maintain fairness. For instance, in Lagos now, during the COVID-19 period, I think there are hospitals that lacked ventilators. So now the question is, okay, who should you give ventilator to? Should it be a young person who still has maybe a promising life ahead? Should it be someone that is old and is about to die? Or maybe a middle-aged man? The best practice to offer to them, so the best practice that that a provider can use in this kind of scenario now is the person that needs it the most, not based on age or whatever may be seen, but whose condition is most critical. That is what the person will use in deciding who should get the ventilator. That's in the case of scarcity. Then regulatory complexity. So due to intricate landscape of healthcare, navigating through the various regulations, institutional frameworks, and insurance policies can be daunting and often results in miscommunication. But in whatever they do during negotiation, they must ensure to abide by the regulatory compliance or frameworks in order to ensure that their contracts will not end up being a bad contract, but a good one, because they are going to be following the laws. Next slide. So hospital physician contracts. So this is our third subtopic. Is just as I said earlier, contracts is an agreement, and the hospital physician contract is an agreement between the hospital, the clinic, like that sort of thing, and the physician. Physician now can be is the provider, that's the doctors, the staff, the healthcare professionals. So it's the agreement between both parties. Next slide, please. So there are different types of hospital physician contracts. The first is physician employment contract. So basically what is involved in this form of contract is that to address okay, if you're going to draft a contract for to employ a particular person, you must include the person's benefits, the salary, the working conditions, perhaps you work from 9 a.m. to 6 p.m., whether you're going to be on call duties or you not come in the night, and the process that will lead to the termination of the particular staff. The second one is the physician recruitment contract. If you are going to recruit a particular physician, what is the method? What are you going to use to attract the person to the facility? Are you going to offer more income? Is it going to be maybe based on financial incentive or relocation assistance? Okay, can be like, okay, we have a doctor's quarters here in the hospital. If you work, you are going to be you're not going to be charged to pay rent. Very catchy bonus or benefits to recruit a person to work in your hospital. Then a medical director contract. So now most hospitals they have this a chief medical director. So the contract is going to specify what is the method of employing a medical director. Medical director, like that's like the head of the hospital, and the responsibilities for director also. Then the fourth one is independent contractor contracts. So this form of contract is for doctors or physicians who are not permanent staff. They just maybe once in a while that a case would occur and they need their expertise, they'll call them in. For example, neurosurgeons. They're not like a permanent staff in any hospital particularly. So each time they have a problem with somebody's brain or something like that, they'll just call them in. So now that sort of a staff, how will you pay the person? So this kind of contracts would specify how you pay the person, maybe per service offered or per month. That's Yes, that's a good example of an independent contractor contract. Then locum tenens contract. So for locum tenens, now the meaning of locum tenens is to hold a place of another. That is a Latin phrase. So locum tenens contract. So this provides temporary assignments for physicians to fill staffing gaps, typically lasting weeks to months. So what this would do is that maybe, for example, if a physician gets sick or if he becomes indisposed and is not like planned for, or if he's on leave, they can easily get local tenants staff that will come and fill in temporary for them. So this will allow for continuity of service and for treatment of patients, so that there'll be no break in that treatment of patients. Also, this also happened in Lagos during the COVID-19 period. They were lacking staffs. So they had to, call other physicians from other states to come and help for that period of time. Know that they would not be permanent workers. They're just going to fill in temporary for that period. So this kind of contract will specify what benefits will be given to those local tenants staff, how will they be paid, how will they be reimbursed for, for their services that they're going to be offering. The next slide, please. So those are the types of the physician hospital physician contracts. So the key components of this contract is one, compensation structure, salary or incentive, then the benefits, health insurance, leave, retirement. So this is very important because it should be specified in the contract. When you're getting a job, you should know what you're getting into. You should know the kind of things that's going to benefit or that they're going to benefit. For example, health insurance. If you are going to work in a particular place, are you going to be giving health insurance or maybe either fully or partly? At what point are you going to take your leave? Is it going to be once in a week, or is it going to be for a week, or is it going to be for a month, or retirement? So for retirement, there's no particular age for retirement, but if you're a government established hospital, their retirement age is from 60 to 65 years old or 35 years in civil service. But for private hospitals now, there is no particular age for retirement. So maybe they can just retire maybe at the age of 70 or 75, as long as they can keep on working. And this is also applicable in the US. There's no particular age for the doctors or for the physicians to retire. Then in this kind of contract, they must specify the terms and conditions, like work schedule. As I said earlier, will you be working from 9 a.m. to 6 p.m., maybe 9 a.m. to 4 p.m.? Are you going to be on call duties? Call duties like you're going to stay back, you're going to be work during the night for emergency patients or patients that might need your help. So for doctors like gynecologists, they have call duties which they rotate. That's they work during the night. Meanwhile, doctors like public health doctors, since the nature of their work is not it's not like an emergency like that, they do not have call duties. They only work during the daytime. Any other case can easily be carried over to the next day. Then liability and malpractice insurance also needs to be specified in the contract. Restrictive covenants, there are clauses that prevent physicians from competing with their employer after leaving, such as a non-compete clauses. For example, if the cardiologist in that particular hospital is going to be leaving or is going to be resigning, or if they're going to be terminating the contract, they can include this restrictive covenant in which you specify that you are not to open any hospital maybe 5 kilometers or with 10 kilometers within the radius of this particular hospital. Like you cannot open a hospital close by. That's to avoid competition. Then lastly, dispute resolution. This is like the fulcrum of every contract. You must specify the methods used to resolve disputes. Is it going to be through litigation? Is it going to be through negotiation or arbitration? No matter how perfect the contract is, you must anticipate that problems may arise, even if it may not really be the fault of the parties, but problems may arise. And if they do arise, you must specify the method used to resolve these disputes. That's why it's very important to include dispute resolution in the contracts. Next slide, please. So the legal consideration. So the the framework that they should consider when making up a contract. So regulatory compliance. So they must ensure that the contract is in line with the regulation. For example, labor and employment law. So labor and employment law would ensure that Section 17 states that all employers should ensure that the working environment is fit for the staff. That's a good working environment or a safe working environment. Now, if the environment is not safe or good enough, they're not guaranteeing the safety of a patient. So if a nurse now is to get infected because there is no glove or there is no maybe sanitizer, the hospital will be held liable for failing to provide the necessary equipment that she needs or that she needed to ensure that she'll be safe at work. The other thing there is the fair market value. So compensation must reflect market rates and regulatory violations. So if the way the country is becoming these days, I said earlier that what you can afford before is becoming difficult right now. So what is the compensation that is going to be made to the physicians now should reflect the market value of or the present market value of what is going on in that particular area, to avoid paying them less of what services they have offered. The third thing there is the licensure and credentialing. Physicians must maintain valid licenses, certifications, and hospital privileges. Then Restrictive covenants, I've explained this earlier, and termination clause, I've also explained this, because contracts must comply with labor and employment law and medical staff bylaws. So basically, I'm just saying that in the making of the contract, they must put into consideration these legal frameworks so that it will be in line with what the laws are saying and what the regulations are stipulating that they should follow. Next slide, please. Thank you. So the next one is managed care contracts. So these are health maintenance organizations. You can also call them insurers. So they're like insurance companies that they'll be paid premiums and they'll pay for your hospital services. So the way this works is that if a patient will sign up for a particular maybe insurance package, they'll be paying premiums, maybe example 5,000 naira each month. Then if they fall sick and need a service, they can go back to them and that insurance company will cover their treatment either fully or partly, depending on what they are paying. So that's it about the managed care contract. Next slide, please. So the key terms and effects of this form of contracts. So network participation providers. So now when you go to that particular insurance company, they will have a list of providers, list of hospitals that they are working with. So now they'll give you options to go to any one of them. And if you can go to any one of them, they're going to cover the cost for you. But if you do not want to go to any one of them, then you're going to be paying from your own pockets. The other one there is capitation. Capitation is payments model where providers receive a fixed amount per member per month to manage care for enrollees regardless of services rendered. So capitation is a subtopic on its own, which I'll be explaining later. So I'll not talk so much about it right now. Then assignment of benefits. So providers agree to accept payment directly from the MCO, limiting the ability to bill the patient for the difference between charged and allowed amount. So for example, if the insurance company are going to pay 70,000 naira for, let me say, child care, and the hospital is demanding 100,000 naira. This form of managed care contract now to specify who is going to bear the loss. With the hospital add up to make it 100, or with the insurance company make it add up to that 70 to make it 100, or is it that the patients now have to pay out of their own pocket to make it 100? So it's going to determine what form of who is going to pay the balance. That's the effect of this form of contracts. Next slide, please. So the adaptation strategies for providers. So now what can providers do to adapt to this form of contracts? The first is strategic contracting. They develop a strategic approach to contract negotiation and management to align with organizational goals and improve the payer portfolio and revenue strategy rather than just focusing on quick negotiations. So now the providers, which is that the physicians in this instance, they are to ensure that their goals are met. I'm sure they're not trying to work to operate on a loss. So when I get into this kind of contract, they must specify who is going to bear the loss, what benefit are they going to be getting from this particular form of contract. Of course, everything is going to be discussed during negotiations. The second one is data analysis and performance monitoring. So, the very important thing about the contract is to monitor it so that each side will play their own part. And so when you monitor it, if any party is defaulting, you can easily, call that party to order, or, choose the means you have picked to resolve that form of conflict. Then value-based care. So they can also be paid based on the value gotten. Not that's not based on the volume, but the quality. For example, if you are going to be paid based on readmission rates. For example, if you are going to treat this particular patient and there's no readmission, the person got better very quickly, you're going to be paid you're going to be paid more because now the patient recovered quickly, which shows that you're doing your work well. But it's a problem with this form of contract, which I'll be discussing under a different subheading, that's value-based contract. So I'm not going to speak so much about it in this particular slide. Next slide, please. So insurance contracts. So insurance contract is a legally binding agreement that allocates risks between the insurer, that's the payer, and the insured, that's the policyholder. So in healthcare, this contract governs the financing and reimbursement of medical services, shaping the relationship between patients, patients, providers, and insurance. Next slide, please. So under this insurance contract, there are different types. These are now the payer types. So there are basically two forms of payers. We have the private payers and the public payers. The private payers, now we have the commercial health insurance. The commercial health insurance are like private insurers, and are called commercial because they do it for the profits, what are going to benefit from it. That's commercial health insurance. And we have examples of this form of insurance. In Nigeria now, we have the Leadway Health Insurance, the Redcare HMO, we have the is it Amax? I'm not AXA Mansard. So these are private insurers. They meet hospitals, put them under them, and when individuals pay to them premium and they fall sick, they can easily pay back. But this particular type of insurance, they do it for their profits. The second one is the public or government payers. National Health Insurance Scheme. This one is very, very popular. So that's the government payers. Medicare and Medicaid in the US, or other social community-based health insurance, and self-payers. That's out-of-pocket patients who pay directly for their medical care without insurance companies. That's for patients that maybe they're not being covered by insurance, so they just pay out of their pockets. So these are the types of payers under this insurance contracts. Next slide, please. So the negotiation process, as I said earlier, before we can agree the contracts, they need to negotiate and come to an agreement. And so this is the process now. So for healthcare insurance contracts, they are often negotiated between the providers, that's the hospitals or clinic, and the payers, which is the insurance. Then the second one is the risk assessment and premium setting. They need to evaluate who is going to bear the risks when there is when the amount is not meeting up to the total bill. Who is going to add it up? Who is going to pay it, or will it just be left like that? The reimbursement model, the fee for service, capitation, bundled payments. So this what I'm mentioning now, the fee for service, capitation, these are forms of payments which should be included. That's after deciding when you're agreeing to enter into a contract, the form of service payments must be decided. But as I said earlier, these are subtopics which I'll be explaining later. So next slide. So key provisions in healthcare insurance contracts. So what's just like as I explained this during the hospital physician contracts. So the key provisions are, we have the insuring clause. This is the insurer's promise to cover medical services, either fully or partly. The number two, covered services. So what are they going to be paying for? For example, if you enter into this insurance agreement and you are saying that, okay, the agreement is going to cover childcare, maybe hip replacement surgery, cardiac arrest, or that's that's what the insurance cover. Then now you are going in for a cosmetic surgery to change a particular part of your body. The insurance would not cover that. So when you are entering into a contract, you must be as clean or as wide as possible so that it can cover maybe every illness that you're anticipating in the future. Then the third one is the exclusion. Okay, exclusion, for example, now cosmetic surgery. The insurance company would not cover cosmetic surgery or procedures, experimental treatment, services outside the network. Then premium clause. So it specifies the amount and timing of premium payments. Maybe monthly, maybe the first of every month or the third week of every month. The medical necessity clause. So only services deemed medically necessary will be reimbursed. Then pre-authorization requirements. Some services require insurer approval before treatment. Usually, before you meet the hospital and you carry out any particular care, and you know that insurance company is going to cover for it, you must inform them before undergoing that particular treatment. They have to be informed. Next slide, please. So risk management. So this is like allocating who and what kind of risks each the parties are going to bear. For the insurers now, that's the insurance companies, which are also called the payers. they can get insurance for their own insurance company. That's to protect against catastrophic claims. Sometimes if the payment they're going to make is more than what they anticipated, they'll have to get insurance to protect them from further liability. And also provider network control to manage cost and quality. Then for providers, they would ensure to negotiate fair reimbursement rate to cover operational costs, then professional liability insurance and malpractice cover. Then for patients, they have to understand the coverage. That's what the contract, that's what the insurance is going to cover, the exclusion and out-of-pocket obligations. They're also going to use preventive care to reduce long-term medical risks. So preventive care is very important because now this is like a form of treatment where you can protect or you can prevent certain kind of disease or illness from taking place. For example, we have three types of preventive care. We have the primary, the secondary, and the tertiary kind of preventive care. The primary type is basically what we all do. For example, covering mosquito nets to prevent malaria or me not staying out too late. Then the secondary care now is like checking your blood pressure to track to know that you have high blood pressure or not, or to ensure that your blood pressure is stable. Then going for this mammogram checkup to ensure that you do not have breast cancer. Then tertiary care now, this one you have already gotten the disease, but you're trying to prevent it from becoming worse or becoming more intense than it used to be than it is. So, for example, maybe as a HIV/AIDS patient, you're taking your antiretroviral drugs, or as a recovered stroke patient, they're going for physiotherapy. So that's just an example of preventive care treatment. So I can't see the slides again.
Sorry, I was logged up. I'll bring it up again.
Okay, sir.
Please let me know when I get to the right slide.
Okay, sir.
Hello.
Yes.
I am seeing that your slide is 50.
Yes, sir. There are 50 slides.
Okay. I have patiently been listening to you. You went far beyond the scope of your work. You went into areas that are beyond the scope of your work, that has nothing actually to do with your work. But we'll give you. Dennis, what was the last thing you said?
Oh, I didn't say anything, sir. I just went to the slides that she was on.
Let's have a round off in the next 5 minutes so that we can take the next group.
Okay, sir. So I'll just rounding up now. So we have 5 types of payments: fee for service, capitation, bundled payments, and value-based contracts. So fee for service, this is a form of payment where the providers, that the doctors or hospitals, are being paid separately for each service. That's if they carry out an X-ray, blood test, or any form of or a surgery, they're going to be paid per service. Next slide, please. So for this service is now conducted, are going to be paid. So the advantage of this form of treatment is that quality care is going to be assured. And the disadvantage of form of treatment is that now the physicians may want to carry out more tests in order to to get more to get paid more. And this might be unnecessary tests, things that are not needed. So that's the disadvantage of this form of treatment. So please, can you just move to capitation? Okay, yes. So capitation, it looks a bit like bundled payments, but it's not exactly. This is a form of payment where the provider is paid a fixed amount of money per patient for a period of time. That is maybe perhaps monthly. They'll be paid 100 or 1,000 naira per patient per month. And at the end of the day, if they get more than 100 patients, they may lose. Or if they get less than 100 patients, they may gain more, because now the savings from that particular payment, or the balance of it is going to be going back to the physician contract. So that's for capitation. So can you go to bundled payments now? So for bundled payment, this is a single comprehensive payment that covers all services related to a specific episode of care, such as hip replacement or cardiac surgery, instead of paying providers separately for each service. So bundled payment is like a lump sum that will just be paid. For example, the insurance company, like for this particular patient, would give you 500,000 naira for the surgery, the aftercare surgery, that's the taking care of the patients, taking care of the particular patients after the surgery, the rehabilitation process, everything. So now, if this money exceed what the hospital would use, they would of course save with the capitation. But if it's not enough, the hospital now will have to pay out of their pockets, or make the patients pay out of their own pockets. But whichever way they pick, they are going to decide how to allocate the risks during the formation of the contracts. Then value-based contracts. This next slide, please. So this value-based contracts now is based on the quality of the service gotten. So that the physicians are going to be paid based on the readmission rate or the quality. But what is unfair about this form of contract is that, how do you truly test quality treatment? Is it going to be the doctor's fault or the physician's fault, or is it going to be the patient's fault? So, but although this form of contract is very good because it's going to encourage good quality care, but at the same time, you cannot really test quality treatment, because most times they are doing their best as physicians to ensure good treatment. So medical equipment procurement. And next slide, medical equipment procurement. So this form of yes, this form of contracts now is where the hospitals or clinics are trying to acquire equipment used in treating patients. So what are they going for? They're not really going for cheaper treatment per se, but are going to be going for the most durable treatment. That is, they're going to make a call for proposals for people to supply them a particular kind of machine. Let's say, for example, X-ray machine. Then they're going to pick based on the one that is most durable. Then the vendor that they're getting it from would be the one to install it. And if the machine gotten is a faulty one, they can sue the person. So they are advised to go for machines that, or to meet the vendors that are registered under the Companies and Allied Matters Act. That's where they're going to buy from, because they're certified, and it can easily sue them to recover back what was lost. And next slide, to technology service agreements. So for this one, it can be called TSA, Technology Service Agreement. So the most important thing to note about this form of agreement is that it must be in line with our regulations or compliance to ensure data privacy for patients, and that you're protecting their right, patient's right, patient information, that it doesn't get out. So this form of agreement would cover the scope of service level agreement, data security, and vendor management. So the keywords are very important here. Things like EHR. EHR is electronic health record. For example, no patient record should go outside of a particular country without due permission. Like other things like telemedicine and billing software. This is becoming very popular because most of our information right now are all online. So it's very important to specify the agreements based on TSA. The next slide, please. Contract management. So this is the last slide. So contract management now. So contract is not just an administrative task. It involves the signing, but it starts before the signing. That's the negotiation process I spoke about earlier. They'll negotiate, they'll agree before they sign. And after the sign, it's going to continue, because you must ensure that each side would perform its own side of the contract. That's involved monitoring to ensure compliance of the contract. And if this is not done, you can as well, sue or pick whatever side of dispute resolution that was agreed upon during the making of the contracts. Next slide, please. Okay, I already mentioned is that negotiation and dispute resolution. So for a contracts management now, as I said earlier, just to ensure that both sides are performing, you must ensure that you are monitoring each side. You cannot just leave a contract after signing it. To ensure that each party is going to perform inside of the contract. To ensure for a smooth flow of the agreement. Then they involve dispute resolution. We have three methods. That's negotiation, mediation, and in dispute resolution. Negotiation is just like talking. I said that one earlier, talking to like, okay, what's happening, what's wrong, what should we do, how can we improve these particular terms of the contract. Then the second thing there is mediation, where you bring in a third party, a neutral third party that will that will decide what should happen. Then if that does not work, then you can go to dispute resolution, where you go before an arbitrator, and his decisions are going to be binding on both parties for him to settle all disputes that may have arisen out of the contracts. The next slide, please. Okay, so thank you all for listening. This is based on healthcare contracts, healthcare provider contracts, and this is the presentation for Group 1. Thank you so much, sir. Sorry for wasting time.
Thank you so much, Bernice. Yes, you put slides were quite bulky, right? But well done for handling this very well. So please, can we have Group 2's presentation so that we can quickly get back to Mr. Ebenezer?
Okay, good. From for Group 2. Mr. Dennis, please, could you help to share the slides?
Okay, I'll be doing that right now. Just 1 second. All right, can you see my slide? Okay,
yes, thank you, sir.
Yeah, please go ahead.
I come. Thanks, sir. Okay. Good evening once again, everyone. My name is Priscilla, and I'll be presenting for Group 2. I'll try to be as fast as I can because I see that our time is fast spent. The first presenter already has spoken about health care contracts, so I'll just be speaking on different aspects of healthcare contracts. Next slide, sir. So the first is the legal regulatory considerations. So you can see that healthcare contracts, just like every other contract, they are regulated. They are legal considerations that guide healthcare contracts, and we'll be considering some of them. So the first is the Health Insurance Portability and Accountability Act, and this act is responsible for the safekeeping of health information. So although this particular act is it is not, what's the word? It is not it does not guide our own activities in Nigeria, but it is a popular act in the United States. So it guides the protection of health information, and a breach of it results to serious penalties. So we also have the STARK law, and that's Physician Self-Referral Law, and it is the law that prevents physicians from allowing their financial interests to override the legitimacy of the healthcare. So this law prevents physicians from referring patients because they have a gain in the referrals, that's financial gains. For example, person A cannot refer a patient to person B simply because person B is going to give him some sort of remuneration for the referrals. So the next act here is the anti-kickback statute. So I'll just go on anyways. So we have the anti-kickback statute, and it prohibits exchange of remuneration and discourages the formation of contracts that involve incentives, bonuses, or discounts. So it is kind of similar to the stack law, which also prohibits self-referral. The next slide, sir. So continuation, we also have the Patients Protection and Affordable Care Act. And this act just simply ensures that there is scrutiny on the whole care for patients, and it is just to prevent fraud and also to abuse the trust that patients have in healthcare workers. It also aims at making healthcare services affordable for patients, because we know that in certain places, although in certain places healthcare is made available for the citizens, but in places like Nigeria, majority use private healthcare. So the Patients Protection and Affordable Care Act just helps to regulate the practice to ensure that patients get affordable care and everyone is able to afford care. So the next law here is state law and licensing regulations, and it provides for the regulation of insurance, telehealth, and licensure. Contracts must be according to the jurisdiction requirements. So this particular law provides for the guidelines which healthcare companies such as insurance companies, telehealth companies must meet before they will be licensed. However, cross-border telemedicine require multi-state compliance strategies. So for telemedicine apps, telemedicine services that would be cross-border, that's across different states, there must be multi-states, like different states must come together to come up with guidelines for it. Because if, for example, if an app is going to, or if a telemedicine service is going to be available in Nigeria, in the US, in Ghana, in Dubai, these four countries will have to come together to come up with rules that will guide the telemedicine service. So the next is the Consumer Protection and the International Data Transfer Act, and this just basically deal with patients' privacy and data security. We've been having discussion on patients' data, privacy, security, and all of that, and we know that it is one of the dicey issues that we have in healthcare today. So, day by day after day, we get complaints of patients' data being breached. So this act just aims at protecting patients' data, sets guidelines towards the end that patients' data are protected. Also in Nigeria, we have the Nigerian Data Protection Act, and the act also, although it is not strictly for healthcare contracts, but we see that it also talks about patients' data. So we have policy shift and reforms, and it's just directly reshape contract terms. Most importantly, the contracts must remain flexible to adapt to evolving regulation. So this particular point is just talking about how healthcare regulations must be flexible to show the changing times. Next slide. Okay, so now the financial aspects. The financial aspect of healthcare contracts and transaction encompasses a number of things. So it includes the revenue cycle management, and okay, I would still go into the details later. I'll just list what I'll be talking about. Revenue cycle management, financial management, patient integrity, risk management, and other financial things that fall under healthcare contracts. So we have the revenue cycle management, and it is the financial backbone of the healthcare operation that manages the patient visit life cycle from scheduling to the final payment. So from the moment that a patient walks in and says, okay, I want to get this card, I want to see a doctor, they give the patient a card, or let me say a file, patient pays, then you visit the doctor could say get tested, then you pay to get tested. Doctor could say, okay, you need to get an MRI, you pay. So the revenue cycle management just tracks all of this, and it is just to ensure accountability in healthcare contracts. So the next we have payment integrity, and it involves ensuring that financial transactions are accurate and appropriate, mitigating financial losses and building trust between payers and providers. So payments, just like what it is called, payment integrity, it is to ensure that the healthcare providers, they stay true to their integrity, and they do not, defraud patients. So it just helps to build trust between the providers and the patients, such that over time, patients can come to trust the healthcare facilities. Then we also have risk management, and it is that healthcare organizations identify and manage financial threats from various sources, including clinical errors, data breaches, and system failures to protect asset and revenues, majorly on the part of the healthcare provider. So they just look at things that could pose threats financially, and they get rid of it. For example, earlier I was watching a medical movie, and they had to cut down on certain things. They had to cut down on certain things because the hospital realized that it was not bringing in revenue, and it was kind of crippling the hospital. So the healthcare providers just take a look at the overall the overall activities in the clinic, and sometimes they have to cut off certain unnecessary things that would lead to loss. Also, sometimes I'm sorry, sometimes um they avoid things like data, just things that could bring about lawsuits that would, pose risk to them financially. Also, we have contract negotiations, and that's carefully negotiated contracts which optimize financial outcomes, ensuring that healthcare organizations secure the best value for their investments in services and supplies. So when we talk about healthcare, we must importantly note that in as much as okay, they want to save lives and all of that, they still need profits, because there's no way they would move forward without profits. So they need profits, and they also, go into negotiations with different companies. For example, some healthcare providers partner with tech companies that are producing healthcare technological devices, just towards the end, that they strike a good bargain that would favor both the healthcare provider and the patient also. So there's also business valuation that's essential for transactions like mergers and acquisition. Business valuation determines a fair price and helps to assess the financial health of companies involved in the transaction. Lastly, we have compliance, and just like the previous speaker also spoke about compliance, it just basically means adhering to regulations and internal policies, and this is critical to avoid penalties and maintain operational integrity in the healthcare industry. So healthcare providers must comply with the regulations that have been set, and not just regulations set by the government, but also internal regulations. So you can see that healthcare providers, they usually set laws, something like bylaws, amidst themselves to guide their actions and everything. So they must comply with these regulations to help keep their integrity. Next slide. So we have the ethical and moral dimension of healthcare contracts. The first is informed consent, and we know what informed consent is. That is, the patient must know and must not only give consent but been must have known what he or she is giving consent for. Yes, let me put it like that. So ethically, patients must be fully informed about medical procedures, the risk and the cost. So patient must also be informed about alternatives. So you should not just tell a patient, okay, this is the only option available to you, probably because that would bring about a higher pay. So you must tell the patient every single option that the patient has. So ethically, that has to be done. Then morally, also exploiting a patient's ignorance, e.g., hiding side effects of cost is wrong, even if it is legally valid. So, even if you could say, okay, this you can do this, but you know that there is another way that the patient can there's another thing the patient could do to help to cut costs. You also have a duty to tell the person. So for example, there was a day that I wanted to buy malaria drugs, and when I got to the pharmacy, they told me that okay, we have two different types of malaria drugs. This one is expensive, but this one is kind of cheap, and both actually they do the same work. So I had that choice to make and say, okay, this is what I'll be going for. The person did not just say, okay, take this. This is what we have because it is expensive. So healthcare providers have a duty to tell patients every options available to them and the cost. So the next here is fairness and equity, and it is that there should be equal treatment regardless of social or economic status, and charging excessive fees or denying treatment to the poor may be lawful under private agreement but questionable. So healthcare providers should not provide preferential treatment to the rich and leave out the poor. And in some healthcare institutions, they actually have like private suites for the rich, and they say, okay, these are for VIP patients, which seems so somehow because everyone is sick and everyone is at the hospital to seek help. So every patient should be treated equally. So there's also transparency and honesty, and basically it is just that healthcare providers must not conceal the material facts. They must state out everything, and they should not wait till, okay, let's get into the middle before saying this, but at the beginning they should state out everything to the patients, and the patients should be allowed to make the choice. So honesty builds trust, and deceptive clauses in health or pharmaceutical sales breach moral duty. There's also patient autonomy against professional duty, and it is that contract must respect the patient's right to make decisions about their body. So like the Okonkwo's case that we've always been bringing up, the doctor, the patient did not want a blood transfusion, and the doctor respected that. So regardless of what the healthcare professional feels like, the rights of the patient to make decisions about his or her body must be respected. That's what autonomy is all about. So there's also confidentiality, and it's simply that in healthcare contracts, whatsoever the patient says, it stays between the patient and the healthcare provider. And in fact, this duty is so like rigid, so that a healthcare professional should not, even if he's speaking to another healthcare professional, you should not just randomly or carelessly bring up a patient's case to even another professional. For example, a doctor should not be gisting with another doctor and say, see that my patient, oh, he or she has HIV, like it is wrong. So even within the confines of the hospital, not even outside, now within the confines of the hospital, confidentiality must be respected and upheld. So there's also justice and accessibility, and I've kind of talked about this under fairness and equity. There's conflict of interest, and it is that healthcare professionals should avoid contracts that put financial interest above patient welfare. So in as much as earlier I mentioned that healthcare institutions also need to make profit, but they should not put profits over and above the patient's welfare. So next slide.
I'm sorry, Priscilla, to cut in, but please, if it's possible, can you also try to speed up your presentation? Thank you.
All right, thank you. So we have emerging trends and telemedicine innovations. Since we already spoke about this in the last class, I would just list them out. So we have telemedicine contracts and virtual care agreements, which we all know that okay, it is when healthcare services provided across borders. So there's blockchain in healthcare contracts, and this is just basically for transparent data exchange. There's also artificial intelligence, then there's wearable tech agreements. So the next slide, please. So there's the international perspective. So there's cross-border healthcare contracts. I already spoke about this, although not deeply, but I mentioned it when I was talking about telemedicine services. So okay, I'll just go to challenges in international healthcare contracts. So the first is that countries have different regulatory requirements. So data privacy laws might not be the same. The employment and labor laws, there are different regulations guiding it. Also for professional standards and liability, they are different in different countries. There are different standards that must be met. Although there is a general standard of care, of course, do no harm and all of that. But in different countries, the things that would trigger liabilities might be different. So there is also the varying religious view and cultural practices which affect patients' responses to healthcare generally. Next slide. So there is dispute resolution and litigation in healthcare contracts. Next slide, please. So first, I would talk about the causes of disputes in healthcare. So the first is billing and reimbursement disagreements, like the case that Mr. Ebenezer mentioned about 2 classes ago, that there was no transparent billing. I believe we remember. I don't want to go into all of that. So that is a major cause of disputes in healthcare. There's also conflicts leading to legal claims for breach of contracts as a result of failure to meet with the obligations that have been set down. For example, if a doctor said, okay, I would do this and he could not, deliver, that's a breach of contract, really. So there's also premature termination of agreements. For example, in physician or managed care system, contracts usually specify performance standards and policy benchmarks. That has been explained. So the next slide. There's also regulatory non-compliance and ethical disagreements. Next slide, please. So now there is under alternative dispute resolution, we have mediation, and it is mediation is useful because it preserves professional relationships. It remains confidential, although it is very cost effective. However, it is not binding. So parts sometimes the mediation process does not lead to a particular solution, or even if the mediator says, okay, do this, the parties can decide to not do it. So there's arbitration, and arbitration is binding. So that is, a more, it is more sorry, it is more practiced because there is usually an arbitrator whose decisions are binding on the parties. So there's also litigation, and that's the final step. That's where ADR mechanisms fail or are unavailable. So litigation is actually advisable for parties because there's public accountability and it is binding. It is binding and enforceable. Also, it allows appeals. However, a problem with litigation is that it takes time, a lot of time. So, next slide, please. So, impact of technology in relation to healthcare contracts. Okay, this is just talking about technological inputs, that's electronic health records, telehealth, and all of that, which have been discussed. Next slide, please. Next slide, next slide. Okay, conclusion. Technology has significantly altered healthcare contracts and transactions, bringing forth both advantages and disadvantages. The direct result of this shows the necessity for new contractual agreements that deals with liability, reimbursement, and service quality. Lastly, the convergence of technology in healthcare highlighted the importance of contracts that strike a balance between innovations, legal compliance, patient safeguarding, and sustainable healthcare practices. Thank you.
All right, thank you very much, Priscilla, for helping us handle presentation for group 2. Well done to you and to your team for putting that together. So, Mr. Ebenezer, we want to give you the floor for your discussion.
Okay, can you hear me?
Yes, sir, we can hear you, sir.
I commend the two groups. However, I want to state that none of the two groups touched the foundational elements of contracts. What are the elements of contracts? I believe everybody here is a law student, right? Or a lawyer. You see, this is why I wanted to have introductions. Do you have anybody here who is not within the law field? Do you have anybody who is not a law student or a lawyer? Do we? Participants, can you respond? If you are, unmute and speak. Do we have anybody who is not doing anything law, either as a law student or as a practicing lawyer, or intending law students, or intending lawyer? Okay, so I want to assume that everybody here is a lawyer or a law student rather. Okay, so what are the basic elements of contracts? The fact that we are discussing healthcare contracts does not remove the elements. Every contract you sign, every contract will have the basic elements of contract. So what are they? Anybody can unmute and say that. I want the class to be interactive. If you know the basic, the elements of contracts.
Offer. Can you hear me, sir?
Offer. Yes, Priscilla, you said offer. Yes, no, offer.
Okay.
Who else? Somebody should give me another one.
Acceptance.
Acceptance.
Consideration.
Consideration. Hello, sir. Hello. Yes, I'm in the lecture I told you about. So I'm having a class now. I am in the lecture. Yes, it's okay. Just send me messages on WhatsApp. Just send messages on WhatsApp. I'll look at them. Okay, sorry about that. So, Priscilla, you mentioned offer. Next person, quickly. Any other one?
Acceptance.
Acceptance, yes. Who else? Eniola. Can you all turn on your videos? Can you turn on your videos? Let me put a face to your names. Turn on your videos. Abba, Mr. Imam, I've not heard your voice in this class since I started this thing. So what is the next? Everybody put on your videos, please.
The intention to create legal relations.
Intention to create legal relations. Yes. Who has not spoken? Bolanle, put on your video and answer. Okay, Adiola, your video is on. We've had offer. We've had Adiola, don't turn it off. Yeah, answer.
Consideration.
Consideration. Okay, we've had offer, we've had acceptance, we have intention to create legal relations, we have a consideration. Okay, is there any other one?
Capacity.
Okay, no, now why would you answer Priscilla? I said everybody should take one. Okay, no problem. Capacity to contract. Now, when you are talking about healthcare contracts. Hello, Mr. Sam, Mr. Imam. You are distracting me with your phone. You are distracting me. You are listening to this thing now, right? So okay. When you talk of healthcare contracts, these elements must come in. So, firstly, regardless of the type of contracts, who is making the offer? Let's assume it is a contract of employment. Who is making the offer? Who is accepting? If a healthcare facility puts out a notice of employment, they are calling for application, they are making the offer. If you now apply based on their advertisement, you are also maybe making an offer too. In fact, their advertisement should actually be invitation to treat. Then you applying, you are now making an offer. Them calling you for an interview and you go through the interview and all that, they have accepted, they engage you. Now, you, the person making the offer, do you have capacity to contract to start with? Now, what are the considerations? We say considerations mustn't be sufficient, but must be what? Mustn't be adequate, must be what? Hello,
Sufficient.
beautiful.
Sufficient.
Your elementary contract. Just always put that cap on. Then, apart from that, do the parties intend to create legal relationship? Will it be binding on the parties, whatever it is they are doing? Then, consideration, technical consideration. Must it always be money? Okay, let's look at contract for medical service. Who is making the offer? A contract for medical service. Who is making the offer? Is it the hospital by building their hospital and putting their signage and putting a red cross on top that this is a hospital? It could be invitation to treat. When the patient comes in, is the patient making an offer or the patient is accepting the offer made by the hospital? Now, some authorities have postulated on issue of acceptance, particularly for contract of medical services. Sometimes the acceptance is within a continuum. It's a long range. In fact, sometimes acceptance starts from the patient's house. The patient has not yet visited the hospital, but the patient has accepted, or the hospital has accepted the offer made by the patient, even when the patient has not visited them. We discussed telemedicine in our last lecture. Now, if a patient calls a hospital on phone, The patient doesn't know anything. Maybe the patient wants to do kidney transplants and just Googles kidney transplantation in Nigeria or hospitals that can provide kidney transplants in Nigeria, and a list of hospitals come out. And there's a phone number. And the patient picks the phone and calls the hospital and says the patient is making inquiries and say he wants to visit the hospital. And as the hospital begin to ask questions, what about this? What about this? What about this? And the hospital says, okay, before you even visit the hospital, do this, do this, do this, do this. Has the hospital accepted someone's hand is, okay, sorry, it's not hand, it's my icon. Has the hospital accepted the offer of the patient? At that moment, who is accepting? Is it the offer of the patient? Is the patient's phone call an offer to the hospital? Is the hospital's response an acceptance of the offer? So sometimes, particularly now that we have telemedicine, it is possible that the doctor has not even seen the patient. The doctor has not even seen the patient, but the contract is ongoing. So you know that it must not be written. It mustn't be written. How many of you have gone to hospital for surgery and you now tell the doctor, okay, let me get my lawyer to draft the contract so that, sorry, please. How many of you have gone to hospital and you say to the doctor, before we commence treatment, let me get my lawyer to draft the contract before you commence your treatment? Has anyone done that before? Then you now start drafting. After that, the doctor signs, the patient signs, and you now say, okay, now we have entered contract, you may commence treatment. That is usually not the case. Sometimes your acceptance could be by conduct. You have gone to the hospital, the doctor has examined you. Now, as at this time, at the time the doctor has examined you, is examining you, there's already a doctor-patient relationship ongoing. Then the doctor says, madam, you will need to take an injection. Then he goes in and brings the injection with syringe and needle, and you turn and you pull down your clothes a little so that he can, and you even turn your buttocks. You're already consenting by conduct. And that is a form of acceptance. So at what point does the patient-doctor relationship commence? Let's look at contract of medical service. At what point? If we're looking at the employment, or there are different contracts. There could be contract for supply of pharmaceuticals. There could be subcontract for supply of hospital equipment. There could be contract for even building. So there could be, you know that during COVID-19, I know somebody who made so much million by supplying face mask and hand sanitizer. That's what he was just supplying. But that contract is not what you call on phone and say, bring us face mask. It's still contract of medical supplies, different from contract of medical service. So, firstly, if it is contracts, once you hear the word contracts, before you talk about the type of negotiations and the strategies as Group 1 did, think elements of contracts. One, who is making the offer here? 2, who is accepting the offer? 3, what is the consideration? The consideration must not be money. It could be money's worth. What is the consideration? 4, do we intend to enter into valid legal relationship? Do we have the intention to create legal relationship? 5, capacity to contract. Now, what if somebody is having a business name, or someone just calls his brother because he's in a position and he says, my company, my organization needs this. So we want you to supply it. The person does not have a registered business that is in that line of supply. The person makes the supply. Or the person that has been called to make supply is a 16-year-old boy. Maybe the CMD of the hospital has a friend he likes so much, and his friend passes on, and his first son, the first son of his late friend, is 16 years. And he now wants to empower, as they call it, the son of his late friend. And he gives the boy a contract of 500 million naira to supply maybe nose mask, face mask to the hospital. Now, what is the validity of that contract in terms of intention, capacity, in terms of capacity? Does that 16-year-old boy have capacity under the law to enter into such contracts at that age in his personal name, not in the name of a company? So these are issues. The fact that it is medical service does not in any way invalidate or detract the need for the elements of contracts to apply. That is one. Then I mentioned the contract of medical service. Now, you should know this, that a medical doctor is not a magician. Medical doctor is not a hero. Nobody expects a medical doctor to become a hero. There are boundaries, there are different areas and disciplines. So where a medical doctor is entering a contract of medical service, there are no guarantees. What a medical doctor is expected to do is to provide you care. No guarantees. No guarantees of outcomes. Now, if you take a medical doctor to the Medical and Dental Council, they are not going to check if somebody died. They are not going to check if the patient got well. What the doctor owes you is competent care. Competent care. Now, if he has provided competent care and the situation worsens, the doctor is not liable. If he has provided competent care and the situation gets well, fine and good, or the situation gets better rather, fine and good. But you see, when it comes to cosmetic surgery, there are guarantees. Of course, we also know that there are express and implied terms of a contract. Unfortunately, healthcare providers, a good number of them do not know that as they are treating a patient, it is a contractual relationship that is ongoing. A lot of them do not know that the law is regulating that patient-doctor relationship. They just feel, okay, I'm a doctor, the patient is sick, so I have been trained, I'm qualified and licensed to attend to sick persons. Fine. But there is a law regulating that relationship. So you also know that apart from the elements of contracts, we have what we call terms of contracts. We have the express terms and we have the implied terms. And one of the implied terms of a contract of medical service is that the doctor will provide competent care to the patient. It is not written. No doctor, no patient says, doctor, sign here that you are going to provide me competent care. Nobody even asks that question because it is presumed or assumed that the doctor, having been licensed, is qualified to carry out that particular treatment. Now, the patient does not go about asking the doctor to show his license. No. So, what happens where a doctor now, where a patient now comes to say, I want to undergo cosmetic surgery. You see this, my nose? I want it to be brought to my cheek, or I want my ear to be on my forehead. Once the doctor undertakes that he can perform that surgery, because this is a special kind of contract of health, of medical service. Once the doctor agrees, because firstly, for a healthcare contract to be established, there has to be a request and acceptance between the doctor and the patient. The patient makes a request, covertly or overtly, and the doctor accepts the request. Now, where a patient is rushed to the hospital, this patient is in coma, and the patient is rushed to the hospital. The persons who are bringing the patient are making a request. Once the doctor, the hospital accepts to treat, the doctor has accepted that. Now, do not forget that the patient himself is in coma and is unable to speak. So that means a third party has entered a contract of medical service for the patient between the because initiated a contract of medical service between the patient and the doctor. So, as okay, there is no healthcare professional here. I would have said, as healthcare professionals, always have that in mind, that there are express terms of contract of medical service and there are implied terms. Now, the express terms, of course, like I mentioned for what's it called? Plastic surgery. The express term is that at the end of these treatments, my ear should be here. Now, for ladies, those of you who go to do BBL, it also applies. I think there's one they call boot lifting too. Boobs lifting, breast lifting. They go to implant silicone. Now, all those surgeries have express and implied terms. So what are the express terms? What does the patient want at the end of the day expressly? Whether written or verbal, As far as the patient says, this is what I want, this is what I want, this is what I want, this is what I want. And the doctor, don't forget, the patient makes the offer. We talked about offer and acceptance because we are looking at the elements of the contract. The patient walks in and says he wants to do BBL. And the doctor accepts that he can do BBL. Now, the express term of that contract is that at the end of the surgery, the buttocks of the patient should become bigger than it was when the patient came in. That is one. Now, an implied term of that contract is that by the end of the surgery, the patient should not begin to have rotten buttocks, because we said the implied term is that the doctor will provide competent care. The doctor is not to perform magic, but the doctor will provide competent care. So where the doctor has provided competent care and the patient now refuses to follow the instruction of the doctor, maybe post-surgical visits, post-surgical management of the surgery site until it gets healed, or the routine drugs that the patient is supposed to be taking, where the patient now fails to follow this and something goes wrong, the doctor will not be accused of failing to provide competent care. Is that understood so far? Hello?
Yes, sir.
Okay. Do we have any questions so far? Does anybody have any question? Let me be sure you are following what I'm saying. Any question? Okay. Let me assume that you are following. So your silence means you understand what I'm saying. So let me ask you, how do I put this question? Okay, what did I say? What is the major implied term of a contract of medical service? Hello?
That, yes, sir.
Yes, proceed.
The implied term is that the doctor is to provide quality care to the patient.
Okay. Okay. You use quality care, fine. But the appropriate word is competent care. You know why?
Yes.
I said competent care. We are looking at the doctor's competence. If you say quality care, quality is in grades. Do you understand me?
Yes, sir.
Quality is in grade by grade. So you can provide quality care based on what the patient can afford. By that, I mean there are 4 or 5 different treatment options available. And each of them has cost implication. And this is this. Out of those options, this is the best option, but the cost is high. And the patient does not afford or could not afford that. That does not mean that the doctor has not provided quality care. It means the doctor has provided care within the reach of the patient. But what we are looking at is the competence of the doctor. So if the doctor is competent and provides competent care, the outcome of that competent care should be quality. within, of course, the pockets, the financial muscle of the patient. Is that understood?
Yes, sir.
Because if we are saying quality, quality is graded. But when we are talking competence, competence is competence. We cannot grade competence because once you are dealing with healthcare professionals, once you delve into negligence, rather, you are looking at, oh, excuse me. Hello? Hello? I am in a lecture. I'm in a lecture. I will call you back. I'm in a lecture. I'll call you back. I'm taking a class. Yes, I'm lecturing a class. I'll call you back. Yeah. Okay. So once you are competent, you are supposed to follow the right procedure. You are not in charge of the outcome. You are in charge of procedure. That is competence. You didn't give overdose. You didn't give underdose. You referred when you got to the edge, your wit's end. When the situation surpassed your knowledge, you referred. Now, that is competence. Like I said, a doctor is not a magician. A doctor must not keep a patient and say, I must ensure that this patient gets well by all means. No. Once you have diagnosed and you know what the ailment is, and you know the treatment procedure, you treat. That is competent care. At the moment you have gotten to your wit's end or you have treated what you know, you diagnosed, and your diagnosis is correct, the next thing you do is you refer. Because at this point, I have done all I need to do. I have done all I know to do in this situation, and it's not abating. You refer. Because there is something beyond you there. But where you insist and say, well, you have come to my hospital, you must get well in Jesus' name, or in whatever name you believe, then while you are putting medication, you are doing prayer, you are doing all manner. Once the situation is beyond you and you refuse to refer, it is no longer competent care. So you do not say we must provide quality care and you detain the patients beyond what the ailment of the patient requires. So I needed to emphasize this. And I have said repeatedly, it is not in every situation where a patient dies that the doctor is held liable. Because what the hospitals will look at, it is important you understand these facts. That's what is going to distinguish you from the common man on the streets. Once the doctor follows the right procedure, the competent care, the doctor is absorbed regardless of the outcome. But where the doctor misses a step in the procedure leading to harm, it is no longer competent care, regardless of the qualification of the doctor. Whether he is a professor of medicine, whether he is a consultant of 50, 30, 70 years, it is actually immaterial. So we have looked at offer, and we said the patient makes the offer when the patient makes a call, when the patient visits a hospital, when the patient is brought in coma, or where in a state where the patient cannot talk, when the patient is brought in emergency situation. It could be accident, but the patient cannot talk. Where the patient is a minor, So the patient made the offer. Now, a doctor is not bound to treat. Another vital point, because we are talking offer, we are talking acceptance. A doctor is not bound to accept a patient and treat a patient. Although Section 20 of the National Health Act says hospitals should not refuse or deny patients treatment in emergency situation. Now, what happens where a hospital lacks the competence to treat the patient? We just talked about competent care now. What happens where a hospital lacks the competence to treat a patient? What should the hospital do? I need a response from nobody should talk. I need a response from Olua Funke. Funke. Hello, Funke. Unmute. Funke Ajorin. Hello, Funke. Unmute and respond to my question. Where a patient is rushed to a hospital in emergency, and Section 20 says hospitals should not deny patients treatment in emergency situation, and this hospital does not have the capacity, the personnel to handle that situation. What should the hospital do? Funke and Jorin. Okay, Funke is not. Can anybody hear me? Let me confirm. If you can hear me, unmute and say yes.
Yes, sir, we can hear you.
Yes, sir.
Okay, awesome. So, Funke, you heard me well. Bolanle, what should be done in that situation? Hello, Bolanle, unmute and answer. Okay, Mary Smart.
Hello,
Sorry,
sir.
not Mary Smart. Bolanle, wait, Zion.
Sorry, sir. I was having network issues. I didn't hear the question fully.
Yes. Okay, thank God you didn't hear the question clearly. I have moved from you. Zion, because you have spoken sometime, I have not heard Zion in this class.
Okay.
So Zion, turn on your video, unmute and answer the question.
Okay, sir. Sorry if I'm not in a very, very good place.
There's no problem. So introduce yourself. Have you introduced yourself before?
No, but I've made a presentation before. So okay, my
Okay.
name is
So yes.
My name is Shola Alim Zion. I'm a 400 level law student at University of Ilorin.
Okay.
And
Awesome.
I think I'm going to say why I took
You
this
didn't participate in are you in your health club? University of Ilorin Health Club.
Yes, I am, sir.
Did you participate in the competition?
Sir, no. I was swamped with a lot of activities at that time. So I was like, not yet, yes, sir.
Okay, proceed.
Okay, so the question, since they don't have competent hands to take on the patient, and you're saying last statement you said before asking the question was that they should refer the patient. So because if they take in the patient and then a mistake happens, they're going to be at fault because they're not competent enough to carry out the recommended process or procedure to treat that patient to be all right. So once they say that they're not competent enough or there's no certified personnel to take in that kind of patient, then the patient should be referred immediately. And I think one question I now have is, sorry, I have a question after this. The question is, I think you said in one class that a patient that must never be, a patient that must always never be turned back, a gunshot patient. So let's say the hospital now, they don't have someone that can take care of a gunshot patient, and the law is saying that nobody must refuse a gunshot patient. Would they also have to refer the patient to another nearby hospital? So yeah, that's it. But my own answer is that.
Okay. Now understand the provision of the Compulsory Treatment and Care for Victims of Gunshot Act. As a student of this class, I expect you now to have gotten all the laws we have been citing frequently, the National Health Act, you should have a copy of it. This one I just cited, you should have a copy, either hard copy or soft copy. So the law did not say patients should not be referred. The law primarily said or says that patients' condition precedent for treating gun wound patients should not be police reports.
Okay.
Section 1 says prior to that time, what was in practice was hospitals will first of all request a victim of gunshot to provide a police report before they will commence treatment. So the law now says hospitals should receive and treat adequately persons with gunshot wound with or without police clearance. That police clearance is police reports.
Also.
Do you understand? Now,
Yes.
to make it, to further solve the problem, because if you say this is an emergency, if you say treat without police reports, what about depositing of money? So Section 2 now says hospitals should treat victims of gun wound patients with or without initial deposit of funds. They didn't say hospitals should treat them without collecting money. That's not the law. The law does not provide for free medical treatment. What the law did is that deposit or initial deposit of funds should not be a barrier, or rather, not depositing funds should not be a barrier to the patient receiving care. So once you see the patient, the first thing you do is first aid. Even for that hospital that does not have the capacity to treat. If the person is bleeding, arrest the bleeding. That's the least you can do. Then you refer. You don't dismiss. Referral is not, okay, go to hospital A. That's not referral. Maybe you give direction. Referral is that the letterhead of the hospital, you write on your hospital letterhead. So that it's an emergency, so that when it gets to the other hospital you are referring them to, they'll be attended to speedily.
All right. So.
Do you get?
Yes,
so referral, you would have examined the person you are referring to know that you don't have capacity to handle this.
Okay.
Because we are talking acceptance here. These are, how do I put it? These are implied exceptions to Section 20. Section 20 says hospitals should not refuse treatment for any reason. So a cogent reason is that you don't have the capacity to treat. Because we are saying, when does doctor-patient relationship starts? We are talking about contract of medical service. We've talked about offer. We are talking about acceptance now. When does acceptance arise? And I'm saying that a doctor is not bound to treat. Where a doctor has, because we said the relationship starts where there is an offer and there is acceptance, where there is a request for treatment and there is acceptance by the doctor to treat. The doctor is not bound to accept. That's the point I'm making. That, for example, if, okay, let me complete the first statement. A doctor is not bound to accept, but where he accepts, he must give what? Competent care. Do you get it? A doctor is not bound to accept to treat, but where the doctor now accepts to treat, he is required to give competent treatments. He is required to provide competent treatments. So, one, we have talked offer, the patient makes. Now, example of acceptance. People are traveling in a bus, there is a medical personnel there, the bus has an accident. Or even the medical personnel is not in the bus. The bus has an accident and someone is driving, gets to the accident scene. He's a medical doctor. He gets to the accident scene. Now said, oh, I'm a medical doctor. Carry this person this way. No, don't carry this person this way. Then he begins to do some things there. At that point, he has accepted. Do you get it? Or
Yes, sir.
at that point, he has made an offer to treat. But because the patient is even in coma, the patient has accepted, not expressly, impliedly, because the patient could not accept. The patient is not in a position to refuse. Maybe the patient passed out and the doctor comes in and says, I'm a medical doctor, and begins to do CPR. Nobody invited him. He just rushed and says, I'm a doctor. No, you, that's not how to do it. Stand up, stand up. You, give way. And he takes over. While he was doing that, he did not think that a law is regulating that action. He came on humanitarian basis, volunteered to help. Now, the law will not be against him if he stood by and said, it's none of my business.
Yeah.
The law will not hold him liable. Society might judge him as being callous, as being heartless. Do you understand? But he has not committed any offense. But the moment he says, I am a doctor, and he begins and he takes charge and starts giving instruction, you hold his head, you hold his hand, you give him water. No, don't give him water. Unbutton his clothes. I'll carry him like this. Once he comes in and start doing that, a contract of medical service has kicked in. And at that point, regardless of the fact that he is acting under emergency, he is not in his hospital, he is required to provide competent care. Do you get it?
Yes, sir. Yes, sir.
At that point, he's required to provide competent care. So we say that the acceptance can happen on a continuum. Either phone call from the house and he says, oh yeah, come to the hospital, let me see you. From that moment, acceptance has taken place.
Yes, sir.
Because these are the elements. If an issue comes up, the first thing you are to establish is that there is a contract of medical service between this patient and this doctor or this hospital. Acceptance could be that the patient was going on her business and going about her business and an accident happened close to the hospital and good Samaritans now carry the patient to the emergency. Like I said earlier, the hospital can have valid ground. The hospital can say they do not have a bed space. One of the ethics of practice is that a patient will be admitted on a bed. So if there is no bed space, do you admit the patient on the floor?
No.
Do you get it?
Yes,
do you
sir.
admit the patient on the floor? The law has said hospitals should not refuse patients treatment in emergency situation. So we must also, while we advocate for patients' rights, we must also be dispassionate about it and critically look at the provisions of the law and its applicability in our environment. So where a patient comes in and there is no bed space, what is the right thing to do? Refer the patient. And you need to know that referral is a valid medical service. By the time you refer, the patient may not even know the right hospital. If it is a trauma case, and you go to a secondary, or if it's a trauma case, you took the patient to a primary health care. The primary health care doesn't have, a primary health care center doesn't have the facility to manage trauma. Some secondary health care centers do not have the facility to manage trauma.
Yeah.
So you refer, and that's a valid healthcare service. The patient or the patient's relative will not come back to say, no, we went to this primary healthcare center and they rejected us. Where it will be rejection is where you just dismiss. That's what I call it, dismissal. Where you just dismiss the patient and say, go. Carry am, make una dey go ABC hospital. That's not referral, that's dismissal. Referral means what will ABC hospital use to know that they are coming from your hospital? There is no documents. What you did, you gave direction. So when you talk contract of medical service or healthcare contracts, firstly, there are different types of it. I just focus on contract of medical service so that we can bring, since we are discussing, we've just discussed patients right long ago, so that we can see its applicability. But where you now talk of contract of employment, hospital doctor, hospital nurse, these elements of contracts will still apply. One, then after the elements of contracts, we look at the terms too. And one of the terms of the contract or implied terms now will be that the hospital will provide the patient, the young doctor, the equipment to work with and conducive work environment. Do you get it?
Yes, sir.
So if the person you are engaging is a surgeon and the hospital does not have a theater, we did not, do you get it?
Yes, sir. Yes, sir.
The hospital, these are implied terms. The hospital is not written in the contract that the hospital has a theater, but you are employing a surgeon. By employing a surgeon, there is implied term that you have a theater, which is a good work environment for the surgeon. Then let's assume it is a hypothetical case. I don't want to ever believe it will happen. But let's assume that this doctor has been employed, this surgeon has been employed. Then the first case of a patient who needs surgery now comes, and they are willing the patient to the doctor's office for surgery. Okay, you shouted her. So you see that implied term has not been complied with.
Yes, sir.
That you are supposed to provide the doctor a conducive work environment. You have employed him. Another implied term will be that you provide him PPE, protective gears, that he will use for his own safety too, because the doctors are also predisposed to diseases, especially when they are dealing with blood and the health and the healthcare environment. We talked about hospital-acquired diseases the time we discussed the rights of patients. When we say a patient has a right to what? Which of the rights cover that? Not you, not only you. Anybody can answer. Which of the rights covers what I said now? Which of the rights of the patients?
Sir, please, can you come again?
Which of the rights of the patients protects the patients from acquiring hospital related diseases? Which of the rights of the patient, protects him from getting hospital-acquired diseases?
Is there a specific guideline? So I don't
Anybody
know.
can answer. Yes?
I can't specifically remember if it's right. Just like I'm remembering from an explanation that you gave, where you were saying it as a precaution that to prevent hospital-acquired disease, how that we should not touch the railings,
Yes,
not
it was
touch
under
the
that right that
wall.
I mentioned it. A patient
Mm.
has the right to clean, safe, and secured healthcare environments. So it is under that right.
Okay,
Clean,
so,
safe, and secured healthcare environment. If the hospital environment is not clean, people can come in there and go out with another sickness. So we have seen how healthcare contracts operate, that the elements of the contracts must be captured. Of course, you don't write offer, you don't write acceptance. You have to determine at what point do we have offer, at who made the offer, who accepted. These parties, do they have capacity to contract? Do they intend to enter into legal relation? What is the consideration? Another important point, even for what's it called, even for contract of medical service. Some authorities have argued that consideration need not be money. It could be the mere fact that the doctor wants to, the mere fact that the patient has provided his body to be treated by the doctor is enough consideration, because the doctor wants to prove to the world that he can treat this ailment. Imagine if somebody brings out a cure for HIV now. If a doctor says, I am treating people for HIV, and the government is disputing it. It has actually happened in this country before. A certain doctor came out, said he's treating HIV, and even called for people to come and let him prove that he can treat HIV. At that point, he wasn't saying bring money. Do you get it?
yes, sir.
At that point, the doctor was not saying, come and pay me 10,000 naira or 10 million naira for your HIV to be treated. He was saying, anybody, just come, let me use my medication, you will be well. You will test negative after using my treatment. So you see that the presentation, because it is also a contract of medical service. At this time, the doctor made the offer or invitation to treat. Any person living with HIV that volunteered accepted the offer. Now there is no financial consideration. We say consideration could be something of money's worth. Now there is no financial consideration. The consideration here is the satisfaction or the proof by the doctor to the world and Nigerians that he can treat HIV. That's bragging rights that, yes, I found the cure for HIV. So if the patients submit themselves and the doctor treats them and the HIV disappears, the doctor, 10 million naira from that patient cannot quantify what the doctor has gotten, because the doctor will become a global celebrity. It is not only in Nigeria that people have HIV. In other countries, people have HIV. So anytime you have opportunity to look at any, once you hear contracts or agreements of any sort, put on your thinking cap. First elements of contracts. Once you have them, now, what are the express terms of the contracts? What are the implied terms of the contracts? The express terms, of course, are the ones the parties have agreed, the things the parties want to get out of it. expressly. But there are implied terms of the contract. If you are doing contract of supplies of medical or pharmaceuticals, the express terms will be the list of drugs you were given to supply. The implied term now will be that those drugs you will supply will not be expired drugs. Of course, nobody will write it that you will not supply expired drugs. But understand that in every contract, there is express term, and there is implied term. And that is also applicable to the contracts of medical service. Thank you very much. So, any question? Questions?
Please, do we have questions? Let's go ahead and ask questions while we are about to end class.
Any question? Okay, before we end the class today, we just take your 5 minutes. Turn on your videos, everyone, and introduce yourself. At least I know Priscilla now. Yes, that one I know. Turn on your videos. Introduce yourself if you have not. Okay, Adiola, introduce yourself.
Yes, sir. And good evening.
Good
My
evening.
name is Mary B. Adiola Susan. I'm a 400 level student of University of Ilorin. Yes, I've introduced myself.
Did you participate in the quiz, in the debate?
No, sir.
Okay. Mary Smarts, introduce yourself. 400 Uni Ilorin. So I'm having like 3 of you here now. University of Ilorin. Okay. Are you in your health club? Are you in your medical law club?
Yes, sir.
I will find out. Are you in your medical law club?
Yes, I am. I am now.
Okay. Yes, can we have the next quickly? Particularly those I don't know yet. Benis, introduce yourself. Turn on your camera. Mary Smart, turn on your camera. All of you turn on your cameras. After the introduction, Dennis will take his picture. Okay. Okay, Eniola, introduce yourself. Unmute. Your mic is muted.
All right, sir. Good evening,
Okay.
sir. Good evening, everyone.
Good
My
evening.
name is Eniola Shekaina Anolo Akiton. I'm from University of Ilorin.
Okay. Law student, what level?
Yes, sir.
Okay. Well, this class is for University of Ilorin people. Okay, Benis, can we have you?
Okay, good afternoon, sir. Good afternoon,
Yes.
everyone. My name is Benis Izain, and I'm from Benue State University. That's the formal name. The new name now is Father Dasu University.
Okay,
Makurdi,
Benue State. Benue
Yes,
State
sir.
University. Okay,
Yes, sir.
Makurdi.
Yes.
Okay. What level? Are you a law student?
Okay. I'm a law student. I'm a 400 level.
Okay. Benis Niola Adiola. Okay, Mary Smarts, can we have you? Priscilla, I know you don't need introduction. Zion, can we have you? Turn on your camera. Oluwafunke.
Okay, hello, sir. I was the one that
Okay.
answered the question earlier.
Yes. Unilori too, right?
Yes, sir. Yes, sir.
Okay. Ogoluwa. Okay, Ismail Ogoluwa.
Now,
Okay.
the Bible is talking about our glorified body.
Are you in
We
church?
are not
No.
only walking in newness to this body, but at the end, we shall be glorified.
Okay. Imam, introduce yourself. S.A. Imam Esquire. Leonard Cancer, please introduce yourself. Hello, Imam. Okay, so we have 3 people left. Imam 1, Mary Smart 2, and Oluwafunke 3. Is that a question? Okay, Zion earlier. Okay, Mr. Dennis, I'm done.
All right, sir. Thank you very much, sir, for today's class. Really appreciate the thoughts that you shared. So also the mentees that participated, that were fully involved in class. Thank you so much also for
Is
your
this week
presence.
4 or week 5?
This is week 5, sir. We have one more class to do.
On Sunday?
Yes, sir.
Okay. Hopefully I should take that class on Sunday because Tuesday I may not be available. Okay.
All right, sir. All right. Let's quickly take pictures. I'll be doing that right now. Right. So yes, I'm done. We've come to the end of today's.
Mary Smart is back. So, Mary Smart, can we have you? Ogoluwa, you turned on your camera to take picture and you don't want to introduce yourself. Or you turn it back and introduce yourself. Ogoluwa, turn on your camera. Yes, Mary Smart. Okay. Ogoluwa, yes, go ahead. Unmute yourself, Ogoluwa.
Good evening, sir.
Good evening. So why have you refused to introduce yourself?
No, sir, the network it was fluctuating at that point.
Okay,
So
proceed.
I logged out of the
Okay.
sir.
Okay. So
my name is Akingbesete Ogodua. I'm a 300 level law student at Afebabalola University Ado-Ekiti.
Afebabalola, you people do medical law now or health law? Which one?
Yes, sir, health law, sir.
Okay, are you doing the course?
No, not this level, sir.
What level?
The 500 level, sir.
500. Okay, I know Afebabalola has health law. And I think you also, there's an association or a training your school does in health law too.
I'm not aware of it, sir.
Yes, there's a training your school does in health law. Okay, fine. Mary Smart, are you out of the church now? I hope you are praying for us too. Okay, so on Sunday we will take Imam and Mary Smart. Okay, good night, everyone. Enjoy yourself.
Good night, sir.
Thank you.
Yeah, good night, everyone. Bye-bye.
You're welcome.